This presentation is on endocarditis. It was done by Genevieve Aragon, Aaron Riedman, Angelina Villanueva, and Joseph Hammond. Endocarditis is defined as inflammation of the endocardial layer of the heart.
Infective endocarditis is most commonly caused by Staphylococcus and Streptococcus bacteria. It can also be caused by viruses and fungi. Infective endocarditis occurs when blood flow in the heart allows an organism to infect previously damaged valves or other endocardial surfaces. Vegetations, which are primary lesions of infective endocarditis, stick to the valve surface or the endocardium. Some risk factors for infective endocarditis are prior endocarditis, prosthetic heart valves, acquired valve disease, heart lesions, congenital heart disease, and cardiomyopathy. Clinical manifestations of infective endocarditis are nonspecific and can involve multiple organ systems, but can include fever, chills, weakness, malaise, fatigue, and anorexia. Onset of new or worsening systolic murmurs are also noted in most patients with infective endocarditis. Vascular signs could include splinter hemorrhages, which are black longitudinal streaks on the nail beds, petechiae, which can occur on the conjunctiva or lips, Osler's nodes, which are tender, red or purple pea-sized lesions, or Janeway's lesions, flat, painless, small red spots, which both occur on the fingertips and toes.
Lab values with endocarditis. In endocarditis, the complete blood count should be viewed. Leukocytosis is usually present. Leukocytosis is an increase in white blood cells. This is in response to inflammation in the body. Also, in response to inflammation in the body, there will be an increased amount of immature white blood cells. This is because the body needs to fight off the infection, so it releases immature white blood cells into the bloodstream to help fight off the infection. C-reactive protein will also be increased in the body. This protein is produced by the liver, and it increases when there is inflammation in the body. Erythrocyte sedimentation rate is also viewed. Erythrocyte sedimentation rate is where they look at the settlement of the blood, and depending on how long it takes for blood to settle, that tells you how much fibrinogen is in the blood. Fibrinogen is increased when there's inflammation in the body. So this also helps to determine inflammation. A urinalysis will also be looked at. The organism that infects the heart can also infect the kidneys, so there could be hematuria and red blood cell casts in the urine. Blood cultures are also taken at this time. 2 to 3 are taken depending on the facility and protocols in that facility. The samples are taken 30 minutes apart and on different sites in the body. Diagnostic testing. In endocarditis, an echocardiography will be done. This helps to view the vegetation that may have been done in this infection. In the echocardiography, they also look to see if there is AV block. Sometimes the vegetation can occur around the AV node, causing AV block. Chest x-rays also help to detect cardiomegaly. Cardiomegaly is caused by vegetation, which causes damaged valves in the heart, which causes the heart to work harder, causing cardiomegaly. Cardiac catheterization is usually done prior to surgery if surgery is needed. This helps to assess and analyze function of the coronary arteries. Nursing diagnosis in endocarditis. In our Lewis book, it refers to a couple of nursing diagnoses that are helpful. One is decreased cardiac output related to altered heart rhythm, valvular insufficiency, and fluid overload. The second is activity intolerance related to generalized weakness, arthralgia, and alteration in oxygen transport secondary to valvular dysfunction.
Like many diseases, the best medicine for endocarditis is prevention. Many different conditions may warrant the need for prophylactic antibiotic treatment. As a nurse, learning which patients are at the highest risk for endocarditis can help with early detection and better outcomes. A full patient history can help prevent the incidence of IE, tonsillectomies, respiratory infections, dental work that will disturb the gums and oral mucosa, UTIs, and especially people with prosthetic heart valves can pose the greatest risk for developing endocarditis. Biofilms can develop around prosthetic heart valve material, making antibiotic treatment difficult because the bacteria may not respond. Any previous history of endocarditis puts a patient at higher risk for developing it again. Getting regular dental care and having good oral hygiene can aid in prevention. Getting the right antibiotics started is a priority when dealing with infective endocarditis. Monitoring lab values and making sure the patient understands the importance of adhering to the medication and antibiotic regimen. Relapse can happen, and taking the full course of antibiotics is vital. Avoiding other people who are showing signs of infection or sick is important for the nurse to tell her patient. Often patients are started on IV antibiotics in the hospital and then discharged home. It can take 4 to 6 weeks to clear an infection. Common antibiotics include penicillin, ceftriaxone, vancomycin, or any of these also coupled with gentamicin. Drawing regular blood cultures is needed to evaluate treatment and especially needed to make sure patient levels are in therapeutic ranges for the antibiotics. Occasionally, serious cases may need surgical intervention if the bacteria has infected a prosthetic heart valve. Replacing the valve completely instead of trying to rid the body of the bacteria first is recommended. When caring for patients exhibiting fever, typical antipyretics can be used to help maintain normal body temperature as well as adequate bed rest. Fever, fatigue, and chills may indicate the infection has returned or is not responding as desired to antibiotics. Compression stockings, coughing, and deep breathing exercises are recommended for patients with reduced mobility to help prevent further complications.
Potential complications of infective endocarditis are related mostly to the vegetations that form on the valves and the inner lining of the heart. Heart failure can result when these vegetations impair valve function. Embolization can occur when a vegetation fragment becomes lodged in a small vessel elsewhere in the body. This can happen in the brain, the lungs, the spleen, the kidneys, the extremities, or the heart itself. Other complications include the spread of the infection to deeper layers of the heart, such as the myocardium, sepsis, and recurrent infective endocarditis. Here we see vegetations that form on valve leaflets that can cause valvular dysfunction and eventually heart failure. These lesions impair the ability of the valves to close properly, and in advanced disease can cause holes or fenestrations in the valve leaflets. All of these reduce cardiac output and can lead to heart failure. If a patient with infective endocarditis develops heart failure, you'll expect to see symptoms of weakness, fatigue, dyspnea, and edema. These symptoms may vary depending on the valves affected by the infection and the degree to which the infection has damaged those valves. The heart failure can be confirmed with an echocardiogram or other imaging studies. If a patient with infective endocarditis develops emboli, the clinical manifestations will depend on the site affected. Left heart vegetation can break off and get stuck in the spleen, kidney, brain, heart, or extremities. The manifestations in the spleen include left upper quadrant pain and tenderness, splenomegaly, and abdominal rigidity. In the kidney, flank pain, hematuria, and renal failure. In the brain, the emboli cause neurologic damage that is manifested by hemiplegia, ataxia, aphasia, visual changes, and altered mental status. An embolism in the heart can lead to a myocardial infarction or heart attack. In the extremities, you'll see petechiae, infarction, or gangrene, and these are thought to be the origin of the Janeway lesions, Osler nodes, and splinter hemorrhages that accompany the clinical presentation of somebody with infective endocarditis. Right heart lesions can get stuck in the lungs, leading to a pulmonary embolism. This is manifested by dyspnea, chest pain, hemoptysis, and respiratory failure or arrest. The key to preventing complications of infective endocarditis includes initiating early treatment. For bacterial causes, this includes selecting and implementing an appropriate antibiotic regimen that is specific to the causative organism. If the cause is viral or fungal in nature, surgery may be required for tissue debridement or valve replacement. Embolization can be prevented with thrombolytic therapies. Additionally, there are nursing interventions that can prevent embolization that include encouraging the patient to use incentive spirometry or deep breathing and coughing exercises. However, it is important to observe any activity restrictions that are ordered for the patient. To prevent recurrence of infective endocarditis, prophylactic antibiotics are indicated for at-risk individuals prior to surgeries, invasive procedures, or dental procedures. This concludes our presentation. We thank you all for your time and attention.